Hello everyone, welcome to this video session on neonate management for HIV in pregnant mothers presented by MRCOG Courses. Join us as we explore the recent guidelines for the optimal care of newborn care to HIV-positive mothers. So let's begin this enlightening journey together. So here we discuss this from the point of view of the BHIVA guidelines, which we follow for our MRCOG exam. And as I know, I frequently get many queries from this guideline. So specifically, I have chosen this topic to make this simpler for you. So here we go. So first thing is, we divide the babies into three categories: very low risk, and high risk. So decide the optimal management. Babies have to be categorized into these three categories. Now, what babies are very low risk babies? The babies who are low risk, they are born to the mothers who have been on cart for more than 10 weeks. Mother has been taking antiretroviral therapy for at least 10 weeks. Second thing is the viral load, which you took on the 36-week sample, that was less than 50 HIV RNA copies per ml. Third thing is you have documented 2 sequential samples at the interval of 4 weeks, and they have been less than 50 HIV RNA copies per ml. So 3 things we have to see. Remember, there is not or here, there is and. So all the 3 criteria have to be fulfilled. CART for more than 10 weeks. Second is HIV viral load less than 50 on 2 sequential samples at the gap of 4 weeks. And third is at 36 weeks, the viral load is less than 50 HIV RNA copies. So these infants are very low risk infants. So we have to give them zidovudine monotherapy for 2 weeks only. That is sufficient. Remember this post-exposure prophylaxis, which we are giving here in the form of zidovudine, that has to be started within 4 hours of birth. Now coming on to the second category, they are low risk infants. So in low risk, basically the viral load at 36 was less than 50 HIV RNA copies here as well. But the other 2 criteria, either they both or any one of them is not fulfilled. Okay. So viral load at 36 weeks is still less than 50, but the other criteria, either both of them or one of those is not fulfilled. So therefore, it is basically, this is low risk infant. Now, if there is a preterm delivery, premature delivery in which you have not reached 36 weeks, but the most recent one, the most recent viral load which you measured was less than 50 RNA copies per ml. Right? So here we have only one sample. We don't have 2 sequential samples. So therefore, this is low risk, right? So here also zidovudine monotherapy works, but we have to extend that to 4 weeks, right? Now, what happens in high-risk infants? So here, basically the viral load is greater than 50 HIV RNA copies per ml on day of birth. Whether the baby is born premature, whether is born on term, but the day of birth, the HIV RNA copies is more than 50 copies per ml. So we have to give combination therapy. At least 3 drug therapy is to be used, and for 4 weeks. So 3 drugs which we use are zidovudine, lamivudine, and nevirapine. So these are the 3 drugs we have to use. So combination therapy in the babies whose mothers have more than 50 HIV RNA copies on the day of birth. So they are high risk. So let me revise. Very low risk, mothers having CART for at least 10 weeks, 2 sequential samples having value less than 50 copies at least 4 weeks apart. And third is 36 weeks. 36 weeks value has viral copies less than 50. You have to give 2 weeks of zidovudine monotherapy. That's all. For low risk, 36-week sample has copies less than 50, but the other two criteria are not met. Other two or one of those are not met, or whatever last reading you have, if the baby is born premature, that is before the 36 weeks value you have taken, any time before that, the viral load was less than 50, the last value which you took. So these are low risk infants. Here also zidovudine monotherapy will work, but that is to be continued for 4 weeks. What about high risk infants? High risk infants, any time at the day of birth, whatever the base, the background is, but on the day of birth, the mother has viral copies more than 50 HIV RNA copies per ml. Then these are high risk infants, and we have to give 4 weeks of post-exposure prophylaxis, and that to combination therapy, 3 drugs, zidovudine, lamivudine, and nevirapine. So this is how we have to manage these infants in a post-exposure prophylaxis. Now, the next important thing we need to know about these infants is infant HIV status. So how we'll come to know about that? So we have to monitor. For monitoring, we have non-breastfeed infants and breastfeeding infants. Although as per RCOG, as per NICE, we don't have to recommend breastfeeding to HIV positive mothers, right? So it is not recommended to breastfeed. So non-breastfeeding infants, you have to take samples. First sample at 48 hours or prior to discharge. Second sample is taken as 2 weeks. Third sample is taken at 6 weeks from birth, right? So therefore, it is 4 weeks from the last sample. You took a sample at 2 weeks. Now, after 4 weeks, you take another sample. That will become 6 weeks from the birth. Then you have another sample at when baby is 3 months. 3 months baby, that is 12 weeks baby. So you take sample then. And then finally, for the seroconversion, you look at 1.5 to 2 years. That is 18 to 24 months. So this is non-breastfeeding. Now, breastfeeding infants have more chance of getting HIV. So we have to monitor more frequently. So initial is same. That is, we have to take first sample within 48 hours and prior to hospital discharge. Second is at 2 weeks. But after that, we have to be more frequent. So we will take monthly. We have to go every month for the duration of breastfeeding. And once the baby stops breastfeeding, then 4 to 8 weeks after cessation of breastfeeding as well. And final seroconversion will remain the same at 1.5 to 2 years. So the beginning two, the first two and the seroconversion, that remains the same. The middle two, in which non-breastfeeding, we took only 2 samples. One when baby was 6 weeks and the other when baby was 12 weeks or 3 months. While in breastfeeding, you have to keep on taking it every monthly and at 4 to 8 weeks after cessation of breastfeeding. So that is the difference. So this is all about the monitoring and the post-exposure prophylaxis for the neonates. So that's about the neonatal management for the women with HIV positive pregnancy. Thank you so much for being with us today. Hope you enjoyed the session. If you are looking for more such easy explanations and videos and you find this video helpful, do subscribe to our channel and sign up for the courses to prepare for the exam in 70% less study time. Hope it seems helpful. We have really done a lot of hard work on your side to make things easy for you. And we'll keep on posting such small videos on YouTube. So just follow us. And thank you so much for being with us today, and hope to see you all again with next very informative video very soon. Thank you once again.